So today we're talking about inflammatory bowel disease, or IBD for short. Now, this is a condition that affects millions of people, but honestly, it's often really misunderstood. We're going to break down the two main types, Crohn's disease and ulcerative colitis, and really get into what makes them so different, but also so closely related. All right, let's get into it. This quote right here, it just gets right to the heart of what it's like living with IBD. It perfectly captures that sudden, drop-everything urgency, the way this condition can just completely take over a person's life. It's so much more than a little inconvenience. For so many, it's a constant, chronic battle.
So, what is IBD really? Well, at its core, it's an autoimmune condition. What that means is the body's own defense system, the immune system, gets its wires crossed and launches an attack on the gastrointestinal tract. And it's this friendly fire that causes all the chronic inflammation and the symptoms that go along with it.
And that leads us right into the central mystery of IBD, doesn't it? Why on earth does the immune system, our body's greatest protector, suddenly decide to turn on its own team? Let's take a closer look at this autoimmune attack.
Here's a great way to picture it. Imagine your immune system is like a security guard for a big office building. A really, really overzealous one. And instead of just protecting the place from outsiders, it starts attacking the employees, the desks, the computers, everything inside. Well, that's pretty much what's happening inside the GI tract of someone with IBD. It's a massive case of mistaken identity, but on a cellular level.
So, while IBD is the big umbrella term, it's absolutely crucial to tell the difference between its two main forms, Crohn's disease and ulcerative colitis. They might sound similar, but as we're about to see, the key differences between them are everything when it comes to diagnosis and treatment. Okay, so to really tell these two apart, we need to zoom in on three critical features. First, where is the inflammation located? Second, what's the nature of that inflammation? What does it look like? And third, how does it show up in a patient's stool? Let's break each of these down.
First up, location. And this is a huge difference. With Crohn's, that inflammation can literally pop up anywhere along the entire GI tract. We're talking from the mouth all the way down to the anus. But ulcerative colitis, or UC, is much more specific. It's totally confined to the large intestine, so just the colon and the rectum.
All right, next, how does the inflammation actually behave? Well, Crohn's is famous for what doctors call skip lesions. That means you'll have these patches of inflamed tissue right next to patches of perfectly healthy tissue. And the inflammation itself is deep. It goes through all the layers of the bowel wall. Think of it like a deep pothole in a road. Ulcerative colitis, on the other hand, is a continuous stretch of inflammation. It starts in the rectum and just moves its way up. It's also much more superficial, affecting only the innermost lining of the colon. So it's more like a surface crack in the pavement than that deep pothole.
And finally, let's talk about a major symptom, the stool pattern. This is a massive clue for doctors. In Crohn's disease, the stool is usually non-bloody, but for ulcerative colitis, bloody stool is a classic telltale sign. It's one of the hallmark symptoms, and it's caused by those superficial ulcers in the colon.
Okay, so now that we know how to tell them apart, how do we treat them? This brings us to the IBD treatment playbook, and it's all about getting that runaway inflammation under control.
The whole philosophy behind treating IBD is actually pretty straightforward. You've got to calm down the inflammation. And since we know the inflammation is being caused by an overactive immune system, the main strategy is to suppress or turn down that immune response.
One of the most powerful tools we have are called Biologics. These are incredibly smart drugs. They're basically genetically engineered proteins that act like tiny guided missiles, targeting the very specific parts of the immune system that are causing all the trouble. And here's a little pro tip. If a drug name ends in mab, like Infliximab, it's probably a biologic.
Then you've got immunomodulators. Now, unlike the super targeted approach of biologics, these medications work more broadly. They kind of turn down the volume on the entire immune system to reduce inflammation. So think of them less like a specific patch and more like a system-wide software update.
Now, with a broad-acting drug like Methotrexate, there are some really critical things to keep in mind. Because it works so broadly, it can actually suppress bone marrow, which is a very serious side effect. This is why anyone taking it has to also take a folic acid supplement. It helps counteract that effect. It also means frequent blood tests aren't just a suggestion, they are absolutely non-negotiable to keep a close eye on their blood counts.
So what happens when a patient has a really bad flare-up? Well, that's when doctors often turn to corticosteroids, like Prednisone. It is incredibly powerful at stamping out inflammation fast. But, and this is a really big but, it's meant to be a short-term solution only. Using it long-term comes with some very, very significant risks.
One of those major risks is hyperglycemia, which is just a fancy term for high blood sugar. And prednisone causes this with a kind of a three-pronged attack. First, it gets in the way of the body's ability to make insulin. Second, it tells the liver to just dump more sugar into the bloodstream. And third, it actually competes with the insulin that is there for a spot to bind. It's just a perfect storm for sending blood sugar levels way up.
You know, because the symptoms of IBD can be kind of vague sometimes, getting the right diagnosis isn't always a straight line. It can sometimes turn into a real case of mistaken identity.
So how can a doctor be sure that what they're seeing is actually ulcerative colitis and not something else that just happens to look a lot like it?
Believe it or not, one of the biggest clues is the color of the stool. Remember how we said UC is in the lower GI tract? Well, that means the bleeding results in bright red blood. But a condition like diverticulitis, which can also get inflamed, often causes bleeding higher up in the colon. By the time that blood makes its way through the digestive system, it turns dark and tarry, a sign called melena. It's a really simple but incredibly powerful distinction.
And the confusion doesn't even stop there. Internal hemorrhoids can also cause bright red blood, which might make someone put off seeing a doctor thinking it's nothing serious. And get this, even a bleed from the upper GI tract can look like UC if the bleeding is really fast and heavy. This is exactly why getting a proper, thorough diagnosis is so critical.
Okay, wow. We have covered a ton of ground, so let's just take a second and boil all this down to the most important points you should walk away with.
So if you remember nothing else, remember these three things. First, IBD is fundamentally an autoimmune disease. It's not just a tummy ache. Second, the huge differences between Crohn's and UC really come down to three things: location, the pattern of inflammation, and the symptoms they cause. And third, while the treatments we have are effective, they all work by tamping down the immune system, and they come with their own set of serious side effects to consider.
And that really brings us to our final thought for today. You know, beyond all the biology and the medicine, IBD is an invisible illness. It affects millions of people, but that daily struggle, that constant battle, it isn't always something you can see. So the question I want to leave you with is this: how can we all do a better job of supporting the people around us who are fighting these tough battles that we can't see?